Thank you for staying with us. My name is Vivian Ndegwa, and you are just in time for our health segment right here on Health Tuesday. And today we are going to be looking at the women reproductive and sexual health. And on this particular topic, we're going to be narrowing it down to two conditions that get to affect women, and that is preeclampsia and endometriosis. And joining me for this conversation is Dr. Wachira Murage, who is an obstetrician gynecologist. Welcome to the show.
Thank you, Vivian. My name is Dr. Wachira Murage, senior obstetrician and gynecologist at Savannah Hospital. Thank you very much for having me.
It's a pleasure to have you on set today. Now let us begin with the first condition. We'll do it in two parts. So let's start with preeclampsia. It's a complication during pregnancy.
Yes.
Just tell me about it. What exactly is it?
Okay, thank you very much. Preeclampsia is a condition exclusively for pregnancy. It is a condition associated with elevated blood pressure, and the women also with that preeclampsia tend to have generalized body swelling. And after that, they can have proteins in their urine. It may also have other symptoms like headaches, palpitations, that's a way of the heartbeat, some chest pain. And it characteristically comes after 20 weeks of pregnancy. So it is exclusively a condition associated with pregnancy, not outside pregnancy. And typically we get it after 20 weeks, that's about 5 months of pregnancy. Yes.
So it can't happen before the 20 weeks of
It cannot happen. If it happens before 20 weeks of pregnancy, then we normally say it's chronic hypertension, because that lady must have been having that high blood pressure. But you can also have, because if you look at hypertensive diseases in pregnancy, you can have chronic hypertension. And chronic hypertension is the blood pressure that a lady has all the time. Yeah, that means it's like the pressure me and you can have outside pregnancy. You can have superimposed. That means the lady has been having chronic hypertension, but then they can have now on top of that, now the pregnancy associated hypertension. And that normally will happen after 20 weeks, and it will come with the signs and symptoms that I have described. You can have also gestational hypertension, and gestational hypertension will come without the proteinuria, so they'll have just blood pressure, proteinuria. Most of those people normally will have a sort of a blood pressure even before pregnancy. But preeclampsia is a condition that comes after 20 weeks of pregnancy, then associated with the symptoms that we have described.
Yeah. From the symptoms that you've just mentioned, you know, as you were explaining what exactly it is, when does one need to see the doctor on it? Is it obvious that when you have a headache, it could be that? Or when is it too much?
Okay, normally you can divide preeclampsia into mild and severe. Okay, mild preeclampsia is an outpatient condition. You know, people don't need to be admitted, they're just in hospital. But as regards to when they see the doctor, many times when ladies have preeclampsia, it's a mild one, they do not know. In fact, it is an incidental finding. When they go and see the doctor, and then the doctor takes the blood pressure, they do the urine analysis, they check the urine, and then they find, oh, there is proteins in the urine. So they'll be having some headaches. They think, oh, maybe it's just, you know, common to have headaches, just like we tell our mothers. You know, it's common to have you know, headaches. It's common to have to be aware of your heartbeat. It's common to have this and that, to have some bit of swelling. Okay, when they come to the hospital, it's when now we do a blood pressure and we find, oh, it's 140 over 90 and above. We do the urine, then we get some proteinuria, some proteins in the urine. But when it is severe, they are forced to come to the hospital. Why? Because the symptoms are also very, very aggressive when it's severe. They'll have very bad headaches. Sometimes they have blood vision. They're not able to see properly. They may have some epigastric pain. The swelling may be so much. Okay, sometimes they have disturbance in passing urine. And if they wait for a long time, they can even come in coma, behaving like they are fitting, like someone in an epileptic attack. So you may have those symptoms, but in mild, it confuses our patients. They're not able to come early, so they just come in and we get it as an incident. But when the symptoms are severe, just have eluded, then they are forced to come to hospital because they come and say, "Doctor, I don't know what's happening. I have so bad headaches. I cannot see. My husband tells me I have facial puffiness, I have generous body swelling, I cannot see clearly, I have this pain, I don't know whether it is acidity," They will portray that picture of looking quite sick. And that time they just come to the doctor.
And what causes preeclampsia?
Preeclampsia, the cause is really not known. We only have things like theories, but we know that it is an abnormality of the placenta. And the placenta tends to harden, the blood vessels, because the placenta is full of fine blood vessels. Remember, the placenta is the exchange organ between the mother and the baby. So blood tends to pass through. So what happens at the end of everything, considering all the other causes, is what we call endothelial damage, damage of the blood vessels that are typically in the placenta. So they narrow, right, and harden. So the blood is not able to go to the baby freely, and there is a backlog of blood going back to the mother, and that causes an elevation of blood pressure and damage to other organs. Whatever is happening at the placenta also happens at the key organs, namely the eyes, the liver, the kidney, and even in most organs. In fact, we normally say that preeclampsia is a generalized organ damage disorder. It damages most of the organs. So if the blood again does not pass to the baby, then you have issues affecting the baby. The baby will be malnourished. The organ development will be very poor. Sometimes you can even lose those babies because they're not getting enough nutrition. But as to the cause, it's not known. We all know that there is damage, and there are theories. If it runs in families, you have had, now talk about risk factors. You have had that preeclampsia before, hypertension, pre-existing hypertension before, diabetes, kidney diseases before. So all those conditions are associated, but the actual cause of preeclampsia is not known.
And is it certain that if you had preeclampsia in your previous pregnancy, then it is certain that you'll still have it in the rest of your pregnancies?
No.
Or that's just a myth?
It's just a myth, and you only stand a higher chance of getting a repeat preeclampsia. It's one of the top risk factors. When you're looking at the past history, the past obstetric, the past pregnancy history of a lady, if they have had preeclampsia, then we are very alert during their current pregnancy. Come their 20th week, we normally are very, very alert. We want to see her more often. We want to see on some medication to try and help, like junior aspirin, vitamin E, and calcium that help to improve those blood vessels. So we give them more than other mothers if they have had previous preeclampsia, but it's not a must that they will have preeclampsia in their IDEX pregnancy.
All right. You've mentioned the risk factors, that may lead to preeclampsia, and I wanted to know, is it avoidable? Is there something that one can do the moment they know maybe they're pregnant, or when they're planning for a pregnancy? Is there something you can do to avoid preeclampsia? Is it preventable?
Definitely not. There isn't really much you can do, but we normally encourage mothers that are overweight probably to reduce their, their BMI to come down. If a mother is carrying twins, we want to see them early and be able to just to talk to them and alert them about preeclampsia. If they have diabetes before pregnancy, we want them to have good control of the diabetes. If they've been having chronic hypertension, we want to ensure that they have good control of the hypertension. They have checked their kidneys, their eyes, their liver, and all other organs that can be affected. In terms of medication, then junior aspirin and calcium have a role to play. In fact, we call them antioxidants. And what normally do? They help in the placenta development. So they help in keeping the patency of the blood vessels in the placenta more open, more patent. Remember what we said, that the blood vessels in the placenta are narrowed. And that is the case we find even in other organs. The blood supply to the eyes, the blood supply in the heart, in the kidneys, they are narrowed. And that tends to reduce the blood flow to those organs, and that is why there is damage to those organs. So the basic pathophysiology or the basic damage to those organs is the narrowing of those blood vessels. So we use those medications, call them antioxidants. So that's the far we can go in terms of prevention, but there's no complete way of saying, like malaria, if you use nets or something like that, you prevent malaria. In preeclampsia, you can only do, more frequent checkups for the people at high risk of forming preeclampsia. And then those same patients, you can give those antioxidants which help to improve the vascularity of those organs.
All right.
Yeah.
Maybe what are the complications, or what complications does it or can it cause to the you've mentioned what it does to the mother, but also what about the baby? What complications does it cause to the baby?
Yes, thank you, Vivian. You look at the complications of preeclampsia into two, maternal and fetal. So maternal is what we have just alluded in terms of head organ damage, and quite aggressive. And to the mother, we need to mention the eclampsia. That is the worst state of preeclampsia, where you have all those severe symptoms that you have mentioned associated with fits. So a patient will come with grand mal epileptic fits, and those are normally an ICU kind of management and immediate delivery. So when you're looking at the baby, remember what we said, that the basic pathology is happening at the placenta level. So that exchange organ, the placenta, which the baby is lying on, is not available. It's not working at the optimal way to be able to supply the baby with the oxygen and the blood. So what happens to the baby? Of course, they'll be malnutrited. They will not grow well. So you have intrauterine growth restriction. Those babies are likely to be delivered early. So there's an aspect of prematurity. So those babies will come with poor organ development when they are born. They'll come with damaged organs. So those babies, you kind of get things like jaundice very easily. They get infections very easily. They are anemic. They may have kidney failure. And all the complications, even bleeding in the brain, they're not able to digest. Yeah, so those babies have all those symptomatology of uterine growth restriction. Those babies can also die in utero, what we call intrauterine fetal death. Why? Because that placenta, remember we have said the placenta is abnormal. So what happens, the placenta will kind of slough off. It can actually peel off. In a condition we call abruptio placenta, abruptio, like it peels off. So what basically that means is that there is no now blood going into the baby at once. There is no oxygen going to the baby. So the baby is curtailed from the supply and can die immediately. That can also be associated with very severe bleeding to the mother, to the point that they can go to theater. The uterus refuses to contract because it has been affected. The blood supply also to the uterus is affected. So the uterus remains boggy. Okay, we call it uterine atony. And such a lady can actually lose their uterus. They can go into shock, okay, and they can actually go for ICU treatment. But basically for the baby is the fact that the baby does not grow optimally. It will be delivered early, and it can actually die in utero.
Oh, wow. Okay. Before we get to the treatment options of that, I've read that preeclampsia can also happen after pregnancy. They call it postpartum preeclampsia.
Yes.
Tell me about that.
Yes. In pregnancy and after delivery is a period called puerperium. Puerperium is from what we call delivery, that is the third stage or fourth stage of delivery after you cut the, the cord, right? From that time to about 6 weeks. That one is normally called puerperium. Technically and physiologically speaking, that lady is still pregnant. Why? Because the hormones of pregnancy are still in the lady. So anything that can happen during pregnancy can also happen during that puerperium. And such preeclampsia, the postpartum eclampsia can happen. We have seen of ladies that they've been okay, but the pressure start going up, they start having swelling. Some even go into the eclamptic state that we have described. They have gone home, they are breastfeeding their babies, and then all of a sudden someone gets them fitting and they're brought to hospital and they're in eclampsia. So it can happen because of that physiological state of the mother. Although it's reducing, the hormones are reducing, the swelling is reducing, but they can still have the same conditions that they can have during pregnancy in that particular puerperium stage.
Okay. What are the treatment options available?
The treatment option available depends on the severity. In mild preeclampsia, and especially if the blood pressure is just 140/90, you can just do conservative. And conservative including maybe control the pain, monitor the baby, monitor the head organs, the kidney, the liver, the blood, because they also tend to lose a lot, to have low platelets, and therefore they have a tendency for bleeding. So monitor all those and see them quite often during the antenatal period. If the blood pressure is 150 over 100 and above, then you can institute now the antihypertensives. So you see them more closely. There will be a need at that point to admit them, to be able to control the blood pressure, to be able to monitor the head organ damage, to be able to monitor the baby, and to be able to even prevent the occurrence of the eclamptic state. The seizure prophylaxis. You're preventing the lady from developing those high blood pressures. So you admit them as inpatient. The mild is just an outpatient treatment with more, of course, more frequent follow-up. But when now it is severe, you may need to institute treatment. Once they stabilize, the head organ is okay, the baby is okay, and they're still less than 34 weeks, then you can send them home and see them more frequently. If you have that severe preeclampsia after 34 weeks, then you may be forced to consider to deliver that mother, because the definitive treatment of preeclampsia is delivery. Because remember, we have said it's a related condition. So when the pregnancy ends, now you start having the symptoms tapering, then the mother, kind of heals. So you can use now the antihypertensive drugs. Consider to even develop the lungs of the baby, especially when you have now severe preeclampsia, or what you are calling this is as preeclampsia with severe features. The severe that we are talking about is a blood pressure 160/110. You are talking of protein or more. They may have epigastric pain. They may have very, very severe headaches. And when you do look at the head organ damage, you can clearly see that the kidney is affected, very low. You can look at the liver is also affected. All those organs have severe features, and that is now when you're looking at delivering. So at that point, you're monitoring closely throughout, using other ways to make sure the baby throughout, because remember what we said, the baby can die in utero.
Yeah.
So you don't want that to happen. Also a cesarean section. It is not mandatory, but on the event of a really an emergency, to do a cesarean section. And then you have to have an ICU, because that mother can go into eclampsia. Of course, they are using what we call magnesium sulfate to try and prevent, the cramptic fit. So it's a kind of a very aggressive state. You're monitoring the blood. Because again, they also tend to have kidney, shut down at that particular point. But if they do not stabilize, then you're looking into delivery. And delivery, need of delivery, the primary mode of delivery is normal. It's better. Remember, this mother has complications, so you don't want to take them to theater. Absolutely needed. Necessary. Yes. You want to assess the cervix, and if the cervix is stable, many times you find them in labor. The cervix is open, they are controlled. You just want to deliver them. But if delivery, normal delivery, time that you order an emergency cesarean section. Yes.
All right. Pre-eclampsia, and remember, today we are looking at women's sexual and reproductive. We're going to be tackling two conditions. We've tackled one of them, which is pre-eclampsia, and the next one is, so I want us to get into endometriosis. What exactly is this condition?
Okay. Condition that every woman needs to know about, where the inner lining of the uterus, the cells of the have gone to other areas. And endometriosis causes stress, a lot of pain, because that's the main challenge for because of the area, those cells of endometriosis, the cells of the inner lining. Remember, every month in productive age group between 15 to 49 years have to have the menstruation if they are normal. What happens is that there is shedding of the inner lining. There are some cells called endometriosis because of the hormonal interactions. So they shed, and the blood comes out through for about a period of 3 to 7 days, and then they are okay. So what happens in endometriosis in other areas? In fact, we equate endometriosis to a form of cancer. The way you can imagine, endometriosis can even go to the brain, it can go to the chest, it can go to in fact, we have had ladies who cough blood during periods because of others pee blood because of endometriosis, because it's in the bladder. Others will poo-poo some stool mixed with blood because there's endometriosis in the gut. So it's that presence of in other areas apart from the lining of the uterus.
All right. Yeah. Thank you so much for giving us that definition. Right now, let's take a very short come back. We get deeper into endometriosis. Stay tuned. And I believe this is when it's severe, the coughing of blood in your stool, and also in the urine, but also pain, the like excruciating pain is one of the symptoms of endometriosis. And if I may say, we've normalized, you know, most ladies cramp, we call it cramping, you know, and we've normalized. It's the norm. When I'm on my periods, I cramp. So where do we draw the line of this pain of cramping? Endometriosis.
The pain for endometriosis is very, very serious. When it means to come, a lady like that cannot come to work. A lady like that, they will not be able to attend even to any of their normal activities. So it activities of daily living. Endometriosis, pain, comes periods and goes with the periods. And then after periods, it goes down. When you have now 3, we'll discuss about the staging, then you may have some lingering pain onwards. But typically, comes just before periods and then peaks with periods and then kind of reduces. Very excruciating. They use the normal painkillers, okay, the initial pain. They institute maybe even a second one, it will not work. They'll even go to hospital and then have the injections. It will be able to control. So that kind of a severe pain, which is not being controlled with a regular pain, needs to find out, could it be endometriosis? Endometriosis pain is also inflammatory disease. And in many setups, and many of us, you know, the health providers, treated ladies over many months and many years as pelvic inflammatory disease. Diagnosis for endometriosis, but the pain for endometriosis can be very, very excruciating. So you can't miss it. Yeah. Of course, there's need, as you're going to talk later, other endometriosis, because there are other conditions that can actually mimic and can cause confusion, like kidney stones, ovarian cysts, urinary tract infections, things like, you know, gut symptoms, appendicitis. So we also say that can be a diagnosis of exclusion, because endometriosis, as you are going to see how to make diagnosis, you'll find that direct, you know, way of making a diagnosis of endometriosis. You may have, you know, of investigations and clinical assessments, including thorough history, and narrow down to endometriosis. Okay, so
that's how it is diagnosed.
That's how it's done, yeah.
All right. Yeah. So 1 to 10 women, you know, of childbearing age globally. And is it from your first menstruation, or it can come later on?
It varies. It's early, it may start late. Remember, even the cause for endometriosis is also a bit early. We do think that they have retrograde menstruation. Instead of the menses coming down, retrograde. Yeah, those ones may start early. The young ladies with uterine abnormalities, when they're starting their first menstrual cycle, they may have immediate reason to have endometriosis already abnormal. So it varies from woman to woman. So some may start early, others may wait longer. To the point of onset.
Are there females who are more prone to it, or what?
The risk factors, of course, is all women who are early, you know, in childbearing age, who start menstruation early. Okay, the ladies obese. The ladies with uterine abnormalities also are prone. Some that have had surgeries before, like cesarean section, surgeries for removal, or even have surgeries for removal of the uterus as well. Okay, those are the ones, the risk factors for endometriosis. But into the causation of endometriosis factors, apart from those, they are really, really poorly understood.
What are the maybe that you would love to clarify?
I would want to say one of think that women with endometriosis cannot get pregnant. And if they not have a baby, which is not true. Yes, we know that endometriosis is a okay, which we are able to manage and have the lady get the baby. That women with endometriosis cannot get pregnant, cannot carry their baby to term. Either that women with endometriosis cannot function, yeah, because there's a lot of stigma. Yeah. People tend to think that these ladies cannot perform. Yeah, they think that they cannot engage, intimately because they have endometriosis. Ladies with endometriosis. So that stigma that has been brought about for ladies with endometriosis, they look a bit, and that comes to, sorry, and that comes an aspect of the ladies with endometriosis feeling isolated. Yeah, they feel that they can even be depressed because they feel that they are looked at in another light. They are not part of the family. They cannot have children. So some of those misconceptions are the ones that make the women a bit stigmatized, which is to the contrary. Yeah.
All right. We've seen in I'll speak about Kenya. In Kenya, who have openly talked about their journey with endometriosis. They've had to undergo several surgeries, several of them. So what, you get to that point? What factor determines you getting to the point in surgery? You're constantly in the theater, getting, surgery.
We now have forums where people are coming up. You have the domain. We have Edo Sisters and many other groups, because endometriosis now, and people have found the need to speak about it. In terms of treatment and approaches, what really causes multiple surgeries is the symptomatology. One, pain. And it's pain associated with a growth. Surgery is more indicated when you have a growth, because endometriosis can cause large growths, endometrial cysts, which now can cause a lot of pain. So you remove them once, they accumulate. When you're talking about deep infiltrating endometriosis, it can infiltrate the bladder. Remember, we said endometriosis can behave like cancer, so it can actually infiltrate various organs. If it infiltrates the bladder, then the pain will not be resolved by medication. With the specialists in bladder, the urologist, and be able to cut a portion of that area in the bladder. And it can move to another organ, like the intestines, and also invade the intestines and cause swellings in the chest. So those kind of masses that cause symptomatology, the lady to go for surgery. When you're also treating infertility and you want to correct the tubes and there are of blood, again you lead to multiple. So recurrence of endometriosis, worsening 1, 2, 3, and 4, and also if you're looking at infiltrating, deep infiltrating severe endometriosis, we are always read to recurrent surgeries for endometriosis.
So endometriosis, like there's
chronic.
no cure to it. You just have ways of just managing.
It's a chronic condition, and therefore the treatment is multidisciplinary. About the gynecologist, and this time, in such situations, we always say a gynecologist for endometriosis. You're talking of maybe looking for a general surgeon, okay? A cardiovascular surgeon, if it goes to the lungs. Very importantly, that most of us as health professionals forget, is a psychologist, because it has a very, very adverse effect. Remember what you have said, you're not able to work, maybe having children is an issue, engaging in intimacy is an issue. So all those things, the way they are looked at, by people, look at that lady, now she's a that's how she behaves. It's like she becomes lunatic, she has a lot of pain, she misses work, so you have a collision at your point of place of work. So a psychologist is a very, very key person. So it's a chronic condition, disciplinary treatment approaches.
And are there lifestyle changes that one can alleviating the symptoms?
We encourage the ladies with endometriosis very active in terms of exercises. Remember, there's a new approach that's now gaining out to the pelvic floor. And the pelvic floor is that area in the pelvis, our organs. And that is an area that endometriosis really attacks. And what does it do? Pain, the ligaments and the tissues undergo spasm. That is a major cause of this. Because of that irritation of that blood that we talked about. Yes, and remember, blood is a kind of tension causes a lot of pain. So we encourage pelvic floor specialists, physiotherapy, and make them know about some pelvic exercises that can relax all those organs. We have now, a good diet, so that because the more the BMI symptoms, the more obese patients we kind of get obese. We kind of get more mind what they eat. We also kind of associate things like smoking or excess taking of alcohol as some of those lifestyle stages that people really need to do it for healthy living in mothers that have endometriosis.
That it has no cure really.
Yes.
But are there maybe advancements in research that are in future, that you're seeing in future, that may maybe bring some light in maybe getting the cure?
What we are basically seeing now happening is that, number one, is medical. That's number one. Okay, there is issues of medical. So in medical treatment, where we are looking at some hormonal treatment, hormonal moderation is helping, because remember, endometriosis is dependent on the hormones. So there are researches that are based on that. How do you improve this hormonal interaction? Because the hormonal treatment that we have kind of blocks the hormones, and therefore one of the treatment is that the women have menopause-like. So there are research going on in that front of medical treatment. In terms, then we have the minimally invasive surgery, and we now have gynecologists who are now super specializing in surgeries that are to endometriosis. So that as a generalist obstetrician and gynecologist, you can go. Then there are those super special. So in terms of skills, there's advancement in skills.
Okay.
So that's about it in terms of the for endometriosis. But I can assure you there's aggressive research going on ways of treating endometriosis.
Yeah. We love to hear that, because it shows that there is hope.
Yes.
Thank you so much, Dr. Show today. We really appreciate, because it was so informative.
Thank you.
All
Thank
right.
you for having me.
You're most welcome. We call it a wrap right here on Good Morning Kenya. Thank you so much to each and every one of you who has been tuned in since the beginning. My name is Vivian Ndegwa. Until next time, have yourselves a lovely day.